Welcome back to the third to the last chapter of AMP2 lecture active videos. So, we're going to be doing our lecture today on the second part of the reproductive system, which is on the female reproduction. Now, let's take a look at first the anatomy. This is a little bit of lab just to give you a little bit of a heads up. There, you're going to have a test on next week. Now, the role of the female is actually more complex because of pregnancy. And in pregnancy, we're going to get it in a different chapter. The one that plays a role in pregnancy will be, well, in our reproductive system, it's not only in pregnancy, it's actually the ovaries. These are our female gonads. And they produce the gametes or the egg. They secrete a female sex hormone, which we call estrogen, or you could call it estradiol, estrone, estriol, okay, and progesterone. Uh, the internal genitalia is located inside the pelvic cavity, which will include the ovaries and the duct system. And there are some accessory organs which is responsible for picking up the egg or the fertilized egg and implanting it. And you have your uterine tubes and the womb, which you call the uterus, and the vagina. And then the external genitalia will be the external sex organs. That is responsible pretty much for copulation, okay, and of course excretion of urine. And this is just a bird's eye view of the sagittal section of the female reproductive system. It's actually a full mid-sagittal section so showing you the vital parts. So let's take a look at the ovaries. And the ovaries right here, okay? And it is, let me say, take a look at, let's change our laser pointer, okay? That's the ovary right there. It's paired structure. So you have one here and one on each side of the uterus, and almost almond shape and about twice as large as an almond. And each ovary is held in place by uh, ligaments, several ligaments. So take a look at, you can see it is surrounded by ligament. Now, the broad ligament, pretty much, the reason why it's called broad, it is really broad, right? It is surrounding the ovary and pretty much covers the peritoneum. And the ovarian ligament, rather the broad ligament, is divided into several parts. Okay, you call the broad ligament the mesosalpinx when you are uh, pointing to that particular part of the broad ligament that would be holding the fallopian tube. You call it the mesovarium, which is actually the part of the broad ligament that surrounds the ovary. And then mesometrium is that part of the um, broad ligament that holds the uterus. So the mesovarium is actually only one of the ovary of the ligaments of the ovary. You have also the ovarian ligament. This is actually like a sole, sort of like rope-like ligament that anchors the ovary medially into the uterus. And you have also the suspensory ligament, and that's actually your suspensory ligament of the ovary. It anchors the ovary laterally to the pelvic wall. Now, the suspensory ligament, the mesovarium are still part of the broad ligament and supports the uterine tubes, the uterus, and the vagina. You could see it all the way down there. And the blood supply of the ovary will be your ovarian arteries. These are branches of the abdominal artery, the abdominal aorta, and the ovarian branch of the uterine arteries. And each ovary is surrounded by a tunica albuginea. And this tunica albuginea, you could see it tracing, my pointer is tracing it. And is then covered by the germinal cuboidal epithelium outer layer, which is a continuation of the peritoneum. The ovary has an outer cortex. You can see that it's a solid organ. It has an outer cortex, so you could see that the peripheral or the outer area, okay, it's called the cortex, and then the inner part, which is actually the medulla, and it contains lots of blood vessels and nerves. And you see a lot of strategically located along the cortex of the ovary, tiny sac-like structures. These are known to be the ovarian follicles, and they do contain uh, immature eggs or oocyte, and they are encased by one or more layers of different, very differentiated cells. Each month, a follicle will pretty much ripen up and ejects the ovary in a process which you call ovulation. As you can see, I could see right there where my pointer is, I could see an egg right there, one of them. See the egg right there in the center. And I think I see also something here. We have the egg right there in the center. And then here too, but I think, and for some of them, the way the slide has been cut is not really like they did not catch the egg fully. But for some of them, they don't have any egg, and they could have been already like um, um, well, depending on the state of the ovary, they could have been already like an empty ovarian follicle, which is a corpus luteum. Now, the duct systems of your female reproductive tract. The uterine tube, this is your uterine tube, does not have any direct contact with the ovary. It does not hold on to the ovary. It ends into a fimbriae. It ends into the an ampulla type thing, and this fimbriae-like or finger-like projection is called the infundibulum, and kind of like secrete a lot of mucus, which will hold the egg when it gets ovulated, and it will have lots of cilia in it, and it will guide the movement of the egg right through the fallopian tube, and so that if it gets to be fertilized, it will be implanting in the uterus. The uterine tube is also known as the fallopian tube, and it's about 10 centimeter or about 4 inches long, and extends from the area where you have the ovary all the way attached to the superior portion of your uterus. There you go. The infundibulum, I'm sorry. The infundibulum is the funnel-shaped opening into the peritoneal cavity, and the ampulla is the one that forms half of the uterine tube length. It's the site of usually where fertilization will occur. And the isthmus is actually the lower medial third that empties into the upper superior lateral end of the uterus. So during ovulation, the uterine tube captures the egg, and then the fimbriae would sweep in the what do you call this, the egg in the ovarian surface to carry the oocyte into the tube. And the uterine tubes outside is covered by, just like what I said, mesosalpinx. So the uterus is a hollow, thick-walled muscular organ. Its function is to receive, retain, and nourish your fertilized ovum. It is usually anteverted, okay, which is the normal position. It is inclined a little bit to the front, or retroverted, which is inclined backwards. So you could in your anatomy, you've already noted that the uterus is shaped like a pear, and the portion where you have the major portion, which is actually the body, okay, and then the fundus is the rounded superior region right there, and then the cervix is right in this area here, which is the one that carries a narrow neck or outlet that projects. As you hit, it projects into the vagina. And the cervical canal communicates with the vagina via the external os, and also in the uterine body by the internal os. So you have your internal os right here and the external os right there. So your uterus will have your mesometrium, just like a part of the broad ligament, just like what I mentioned. Okay, it has also the lateral cervical ligaments, and it will also have the round ligament, which binds the uterus to the anterior wall. Here you could see the round ligament. And here's a full view, again, of the mid-sagittal section. Okay, and we'll leave that to your lab. But okay, just for the background, and I pretty much don't know if you had already studied for your lab. The uterus actually has three walls. It's made up of three layers of muscles, or rather, not really only muscles, but actually like three layers. Period. The perimetrium is the outer serous layer, so it's not a muscle. This is actually the visceral peritoneum. It's a membrane that is peritoneum, which is the wall. Okay, but it is not. It is not actually like covering the wall. It extends into the organ. That's why you call it the visceral peritoneum. Then the myometrium, which is this reddish cover, this reddish layer here, it is the bulky middle layer consisting of interlacing layers of smooth muscles. And this is actually the one that contracts, okay, during childbirth and during also our menstrual cycle, okay. If it does contract really bad, then that's when you have your cramps. And the endometrium, which is the mucosal lining, and you got the mucosal lining, okay, which is made of simple columnar epithelium on top of a very thick lamina propria. And this is where your fertilized egg burrows into it and resides there during development. So the uterine wall is made up of two layers. You have your functional layer, and this is actually the functional layer of the endometrium, and you have also the basal layer, and then below that, okay, you already have the myometrium. So this is your endometrium, these two here. We have your functional and the basal layer. The functional, or the stratum functionalis, changes in response to the ovarian hormone cycles, and this is pretty much what is formed during our cycle and then will be sloughed off again after the cycle, at the end of the cycle. The basal layer, on the other hand, forms new stratum functionalis after menstruation, and they are unresponsive to ovarian hormones. So your uterine wall are supplied with lots of blood vessels. You have your uterine arteries, okay? You have the arcuate arteries and the radial arteries. Just make sure that you know them for purposes of your lab, but I am not really going to be asking you questions except for their role pretty much in the physiology of the menstrual cycle. Well, they thicken, they actually like multiply, okay? Your endometrium will actually be forming from in order to prepare the womb for possible pregnancy. The vagina, okay, is the external genitalia. It is part of an extension into the external genitalia. It is actually a thin-walled tube. It functions as a birth canal, and it's a passageway for menstrual flow, and it's also the organ for copulation. It extends between the bladder and rectum from the cervix to the exterior. The urethra runs parallel to the vagina anteriorly. So you could see that your urethral opening is right there, okay, on top of the vaginal opening, okay. And pretty much the layers of your vagina is actually fibroelastic and adventitia. That's actually the layer of the vaginal canal, and then smooth muscle muscularis. Okay. So your vaginal secretions are acidic in adult females but alkaline in adolescents. The mucosa near the vaginal orifice forms incomplete portion, which you call the hymen. Okay, that's the hymen. Okay, and pretty much the hymen ruptures with intercourse, or sometimes even with very extreme activities such as bicycling. That hymen can already be slowly disappearing. Okay, the vaginal fornix is the upper end of the vagina surrounding the cervix. And then the external genitalia will be your mons pubis. Okay, that's the mons pubis right there. The labia major. Okay, that's the labia major right there. And then the labia minor will be that thin flap right there, this, within the labia major. The vestibule is the recess that is actually within the labia minor, and the fourchette is a ridge formed by joining of the posterior vestibule and the labia minor. Now you take off the skin and some fat and some muscles, and you'll find out that there are glands that is sitting right there beneath the labia minor. You call that the greater vestibular gland. The greater vestibular gland, these are the brown things there, okay, is very much homologous to the bulbourethral gland. They are releasing mucus into the vestibule for lubrication. And then right anterior to that is actually the clitoris. Okay, that is actually the glans, is actually the exposed portion. And pretty much is a counterpart of the male penis. Because the body of the clitoris, is actually the body of the clitoris, has what you call also erectile tissues. And then you have the bulbs of the vestibule. They lie along each side of the orifice. And they are engorged with blood during sexual stimulation. The perineum is this diamond-shaped region between the pubic arch and the coccyx. And this is just an anatomical locating, pretty much like a locating map. Now let's go to the mammary gland. Mammary glands are present in both the male and the female, but normally functional, most especially during lactation, after childbirth in female. Main function is milk production to nourish the newborn. Okay, you have the areola. Okay, the areola is a dark area that is surrounding the nipple. Nipple is the one that is raised. So the suspensory ligaments attach the breast to the underlying muscle. Now you have a lot of lobules. Okay, these are lobules, lobule. Okay, that is carrying alveoli. The alveoli are the lobes, rather the grape-like, what do you call this? The grape-like circular material right there that is going to be filled with milk as the mammary gland produces it. So milk is passed right into the lactiferous duct, into the lactiferous sinuses. Those enlarged areas there are sinuses, and then they open pretty much into the nipple. So from the ducts into the sinuses into the nipple. All right. So breast cancer, guys, is something that is an invasive disorder. It's actually most commonly found among women, but doesn't mean that the men will not have breast cancer. The women are the ones that are most commonly affected. 13% of women will develop the condition, and usually they arise from the epithelial cells of the smallest ducts and eventually metastasize. And usually the risk factor here is the onset of menstruation and late menopause. There are no pregnancies or first pregnancies late in life, or probably no periods of short periods of breastfeeding. And pretty much these are all like signs that would increase the risk for breast cancer. 70% of women with breast cancer have no known risk factors, and that's really like ridiculously like scary. And 10% of those with breast cancer are due to hereditary defects, including mutations. So those people with breast cancer with no known risk factors, such as genetically risk factor, probably would have gone through several moments in their lives, or um, indulging in or exposed to mutagens. Okay. The treatment of breast cancer pretty much depends upon the characteristics of the lesion. It would be like generally radiation therapy or a surgery, which means a mastectomy, followed by radiation or chemotherapy to destroy any strayed cells. And there are several drugs that are for estrogen responsive cancer. Uh, Pretty much, you could have just really pretty much a radical mastectomy, removes the entire breast with underlying muscles, fascia, and associated lymph nodes. Or you could just have a lumpectomy, which is less invasive, most especially for stage 1 cancer. And this lumpectomy is only for small cyst. The simple mastectomy is a removal only of the breast tissue. Okay, sometimes some of the axillary lymph node, but some women really would opt for the removal if it has to be. Okay, just so there won't be any recurrent. So let's take a look at the physiology. And I would like to make mention of the oogenesis, which is the meiosis of the female. It's a production of the female gametes. And I think I'm missing TES right there, which begins in the fetal period. Remember that uh, we are not only different in the way we look and the hormones that we produce among the men, we are also different because when we are born, okay, the moment we are born, or even before we're born, we already have our oogonia, which means our diploid stem cells divide by mitosis to produce the primary oocytes that undergo meiosis 1. So they're now going into meiosis 1. But then they are going to be in suspended animation. So they are suspended under prophase 1. So they will not go any further until we are getting into our puberty. So when we are born, we already have a set of oocytes, a pre-measured number of oocytes that would pretty much be geared to a possible ovulation throughout our reproductive activity, throughout our reproductive lifetime. And they are all under prophase 1. They hold on prophase 1. Now know that when an egg is ovulated, they are ovulated as secondary oocytes, and that's the time when they undergo meiosis 2 to produce the ova. So pretty much these are the different stages, okay, of the oogenesis in the fetal, which starts in the fetal period and ends in the ovulation of an ova when you start your puberty. So what's the difference between oogenesis and spermatogenesis? And take note that there are 3 key differences between oogenesis and spermatogenesis. Now, the production of primary oocytes, which is actually right here, okay, they pretty much occur only in the fetus. With the spermatogenesis with the males, they occur in the testes from a stem cell, which is called the spermatogonia stem cell. So the primary spermatocytes, these will be born right there in the testes. What with the girls, with the females, we are already born with primary oocyte that has happened in the fetal stage, and they are only on suspended animation under prophase 1. Okay, so this is actually where it is suspended right here. It will not be undergoing any division at all. Okay, so the primary oocyte, okay, in the primary oocyte stage, meiosis is arrested in the late prophase 1. Okay, so I just said it. And then in the secondary oocyte, okay, in the secondary oocyte, which is pretty much right in this area here. This is your secondary oocyte. Meiosis here, whenever the egg is ovulated, it is actually ovulated under metaphase 2. So you remember that the egg is supposed to divide, and it's supposed to undergo second meiotic division. Before it finishes up its second meiotic division, it will stop right there on metaphase. So it's supposed to undergo second meiotic division starting on this side, but when the moment the ovulation it reaches metaphase right there, then it is going to be ovulated. So it is ovulated as a secondary oocyte that is in suspended animation again. Boy, the female cycle is really like very fun with suspended animations, right? Okay, under metaphase 2. Okay, now the moment it is fertilized, fertilization pretty much is the only one that could complete or make the egg complete is second meiosis. Okay, meiosis 2. From metaphase 2, where it's suspended animation, the moment the egg is received by a receptor right there surrounding it, then that will prompt the egg to finish up its meiosis 2, and then eventually divide. When it divides, it's going to form the second polar body, and then the other cell is going to be an oversized egg that is the real ova, and you have there your sperm that's actually ready to deliver its pronuclei inside, and it's already going to the moment they fuse, the moment the male and the female pronuclei would fuse, then you have completed already fertilization. So the number of functional gametes between your spermatogenesis and oogenesis is also different. The sperm cells produce from every one spermatogonia, which is one stem cell. One stem cell is capable of producing 4 viable sperms. With a oogenesis, okay, one oogonia or one stem cell will be producing still 4 daughter cells in the end, but 3 of the daughter cells will be polar bodies, and there's only one functional egg. Now, in occurrence, the oogenesis begins in the fetal stage, okay, and that is they are only halted under prophase 1 until we get into puberty, okay, and we end early at menopause. Some females will have menopause at age 50 to between 50 to 55, or 60 for those who are having late menstrual cycles up to that age. Meanwhile, your spermatogenesis would begin in puberty all the way to old age. So those two differences make a man and a woman very different in terms of production of hormones and in terms of their sense of well-being, because they still have their hormones, for instance, among the men, while the females actually would lose it early on at an earlier age. So the error rates are also different between the two. You know that there are many erroneous things happening in the physiology of meiosis between the two. The error rates in spermatogenesis is only about between 3 to 4%, and oogenesis has an error rate of 20%. So I placed it here, guys, just so you will know. Okay, this is a table part of the previous discussion. Now let's take a look at the relationship between the oocytes and the follicles. Oocytes are cells, and follicles are sacs where the oocytes are lodged into. So an ovarian follicle is the functional unit of the ovary that encloses a single oocyte. So this is an ovarian follicle. You could see that the egg is right there in the center where I have my marker right there, my pointer. And then it is surrounded by many smaller, pretty much like well-differentiated cells. Okay, and if you are right here, this is actually a very young follicle. Okay, your ovarian follicle, which in the pregranular, in the what do you call this, in the primordial follicle, you call it, the very young one, it is surrounded by pregranulosa cells. Pretty much, just a single layer of cells is present, and there could be like some granulosa cells that are already present, but the granulosa cells become a little bit thicker. Your pregranulosa cells are looking like simple squamous. The granulosa cells are already more looking like cuboidal cells. So the follicles go through several stages of development. Okay, so this one here is what's called the primordial follicle. There's a single layer of squamous pregranulosa cells surrounding the primary oocyte. Now, if you're going to take a look at what the oocyte would look like here, these are the oocyte, and it's just showing you on this picture here the ploidy of the egg, how many chromosomes are inside it. So in the primordial follicle, you have the meiosis had not begun. This is only when mitosis had happened in the oogonium, and you still have a diploid number of chromosomes in it. Then you have the, what do you call this, the primary follicle. From the primordial, this is now going to begin, the egg now is going to begin the maturation, and it will not undergo meiosis, but during the process, it will need lots of help from the granulosa cells, and the granulosa cells are actually surrounding the egg, nurturing it, nourishing it, and in a follicle. Here in after the primordial follicle, well, the granulosa cells are called the pregranulosa cells. They are simple squamous in appearance. They become granulosa, the real granulosa cells, and they are cuboidal in nature. And then you have the secondary follicle here. They will now be pretty much like surrounded by more than one layer of granulosa cells. And take note that the egg on this end, okay, in your primordial follicle, you have the primary oocyte inside it. Well, once it has undergone or it gets into the first, so your primary oocyte is still here. Once it gets into the first meiotic division, then it's not anymore going to be a primary oocyte. But as it prepares for, what do you call it, as it develops itself and prepares for the division itself, it would still be a primary oocyte. So it is a primary oocyte right here. Okay, when you are a primordial, a primary, and secondary follicles, they all contain primary oocyte, and they all have diploid. This is going to be part of some questions. When a follicle is actually primary follicle or primordial follicle or secondary, they are still in the primary oocyte stage. They have not undergone the first meiotic division. Their ploidy is still diploid, they're 2N. Then when it starts to pretty much like begin its formation of a bigger antrum, okay, here this one happens from puberty to menopause. The secondary follicles will now continue to move on. Actually, some say a lot of secondary follicles produce this antrum already because they will get into it already. So when they do start to mature, the secondary follicles will now start to produce more antrum, okay, and meiosis 1 completes in a vesicular follicle just before the ovulation. So here is actually your meiosis 1. First meiotic division produces one big egg and a small polar body. So here, this small polar body gives away all of its cytoplasm and components, a lot of components, into a bigger egg into the other sister egg, and there is no telling who is actually going to become the egg and who is going to become the polar body. This decision right here is actually random. All right, so uh, then it goes more maturation, and it gets finally into a stage where it's going to be ovulated. Here it's now going to, it has been ovulated already. The ovulated egg is already a secondary oocyte, and it is this one here, a secondary oocyte. But the secondary oocyte is now preparing to undergo the second meiotic division. But the moment it is ovulated, that second meiotic division is halted on metaphase 2, on the metaphase 2, on the metaphase of the second meiotic division. It will not continue into anaphase. It will not continue to divide, okay, until it is actually fertilized. If it does not get fertilized, an egg will not stay on suspended animation under metaphase. It will be so tired. It will, it cannot stay on such suspended animation. It's so big. It is not anymore in the ovary being fed. It has just left its follicle. Okay, so it will deteriorate. Okay. So there are usually between 5 to about 10 very young follicles that would start to actively mature and would develop into, from their secondary state, into a vesicular follicle. But only one pretty much are going to be ovulated. So among the 5 to 10 that are recruited to develop, only one will ovulate. What happens to the other ones that is not going to ovulate? Well, they undergo what you call atresia. Atresia is the apoptosis or the programmed cell death of an oocyte surrounding of oocyte and the surrounding cells, which will be your granulosa cells. And 99% of all follicles pretty much are never recruited until menopause. So here, ovulation pretty much is a monthly occurrence after puberty, and a select few primary oocytes are usually recruited and to get activated. It is caused by high hormonal levels, especially the follicle stimulating hormone. One from this group is really selected, and again, that word selected, we do not know who gets to be selected. Usually it is the dominant follicle that is very close to already into a metaphase 2 that would be ovulated. And for some reasons, there could be, like, what if there's two of them that is up at exactly the same, which is very rare. It's a rarity, at exactly the same phase. Well, then you have multiple ovulation. You will have that female is not anymore going to be ovulating just one egg. Usually, the normal is just to ovulate one egg or release one egg. There could be two eggs that's going to be ovulated, and there's going to be two eggs that's going to be fertilized by two different sperm cells, and that would result in fraternal twins. So after the first meiotic division, there's going to be a development of after the first meiotic. Well, during the first meiotic division, there's already going to be one egg that's going to continue its development and one polar body. Then on the second meiotic division, this egg, here after fertilization, will again divide into second meiotic division, will form another polar body. Meanwhile, the other polar body will divide again. So there should be like 3 polar bodies that would be produced in an entire meiotic cycle of a female that would have the secondary oocyte fertilized. If the secondary oocyte does not get fertilized, it will become stale, it will become bad, and so it would have undergone only first meiotic division. So there's going to be one ovulated egg only and one polar body. There won't be any other division that will happen. So your secondary oocyte arrest in metaphase 2, and pretty much it is the cell that becomes the ovulated ovum. If not penetrated by the sperm, the oocyte deteriorates. Okay, I just mentioned that already. So, okay, let's take a look at the stages of follicle development. Okay, you have your primary follicle, and the primary follicle, and the secondary follicle. You would see a lot of them in the cortex. Okay, the maturation process occurs in two phases. The phase 1 pretty much is gonadotropin independent, the pre-antral phase. It involves follicular paracrines. And in phase 2, okay, it involves the antral phase. It is actually stimulated by the follicle stimulating hormone and the luteinizing hormone. The dominant follicle here is selected, and the primary oocyte would resume meiosis. So the primordial follicle, go back to this, okay, would look like a squamous cell, would have like granulosa cells that are so young, the pre-granulosa cells, they look like they're squamous cells. This process can take about 1 year, okay. We are all born with a lot of, what do you call this, a lot of primordial follicles also in our ovaries. And for the primordial cells to continue its development, pretty much it'll take 1 year. Follicle is now called the primary follicle. After that, the oocyte secretes glycoprotein-rich substance that forms the zona pellucida. The zona pellucida is that dark ring around the egg, which is actually a protein. It encapsulates the oocyte. And right here in this picture here, the zona pellucida looks so blue. You can see that zona pellucida. Now, in this point here, the primary follicle becomes a secondary follicle. Your pregranulosa follicular cells would start to proliferate. They form the stratified cuboidal epithelium around the oocyte. There's going to be lots of them, sometimes more than 2 or 3 layers. Okay, and the primary follicle is now called a secondary follicle when you see about 3 layers. Okay. And sometimes it will have a small antrum development. Okay, the connective tissue and the granulosa cells, they condense to form what you call the theca folliculi. Okay, and theca folliculi pretty much is exactly this area right here. Can you see that purple color area right here? They secrete hormone that is in response to the luteinizing hormone. Now, the secondary follicle becomes vesicular now, which means they form the antrum right there. The secondary follicle stage ends when the liquid accumulates between the granulosa cells. And I'm just telling you that some of the secondary oocyte would really would have this, but they would have come into a point where they're now getting to be big, and they're now going to get and become what you call a Graafian follicle, almost like a tertiary follicle and a third stage 3 of the follicles, which are already a mature follicle. The antrum is a large cavity that is formed when all fluid here would be dumped into. Okay. The antrum now, which is the space that with lots of fluid in it, continues to expand with fluid isolating oocyte. The isolated oocyte with its surrounding granulosa cells are now called the corona radiata. My professor, when I was studying here, used to call this particular egg the princess, and all the surrounding granulosa cells are its the maidens that are supposed to protect her and help her. So when it gets to be ovulated, and you have your secondary oocyte has been ovulated here, you have a group of maiden that would continue to serve the egg until its lifetime, or until it turns into a fertilized egg, or possibly at the end of its lifetime. And that pretty much will be the crown of that princess right there. That's why you call it the corona radiata. So your secondary follicle at this point becomes a vesicular follicle, and after oocyte, after the oocyte and the corona radiata are ejected right here into the outside, then the remaining follicle is now transformed into a glandular structure, right? This is actually it, which is called the corpus luteum. So let's take a look at the ovarian cycle. The ovarian cycle, 28 cycle for a normal female, it refers to a series of events associated with the maturation of the egg. And there are 2 consecutive phases, with ovulation forming the mid-cycle between phases. You have the follicular phase, which is the first 14 days, and from the 14 days right out immediately after ovulation will be a luteal phase. Only 10 to 15% of women have 28-day cycles. A lot of women would go longer than that. Okay. So during the follicular phase, every vesicular antral follicle becomes sensitive to the follicle stimulating hormone and are stimulated to grow. There's going to be one dominant follicle that becomes especially sensitive to the follicle stimulating hormone. And that one dominant follicle pretty much would, whenever the levels of the follicle stimulation drop around the middle of the follicle phase, the dominant follicle will outcompete other follicles, and it is the only one that will continue on. The non-dominant follicles will now die and undergo atresia. The primary oocyte of the dominant follicle completes meiosis 1 to form the secondary oocyte and, of course, eject the first polar body. The granulosa cells then send signals to the oocyte, causing it to stop meiosis. So it is going to be halted in meiosis 2 when it is ovulated. So ovulation itself pretty much is the rupture of the follicle, the mature Graafian follicle, and some few women would feel a twinge of pain. You call it the Mittelsmurch. That happens only at the point where ovulation or the release of the egg happens. Now, well, just like what I said, if there's going to be a release of more than one secondary oocyte, okay, then it will result in fraternal twins if they are both fertilized. They should be. Now, in some women, oocytes may be released at times unrelated to hormone levels. So after ovulation, the ruptured follicle would collapse, the antrum fills with clotted blood, and now is known to be the corpus hemorrhagicum. And then the remaining granulosa cells and internal thecal cells enlarge here to form the corpus luteum. The corpus luteum cells will now be secreting progesterone and some estrogen. If no pregnancy will occur, the corpus luteum will degenerate to become a corpus albicans. There you go. That's a full corpus albicans right there. And it is albicans because it's really very white. It's made up of collagenous material. But if pregnancy will occur, this corpus luteum will produce hormone that sustains pregnancy until the placenta takes over. So the corpus luteum would persist for about 3 months. So let's take a look at the regulation of the ovarian cycle. Before puberty, just like what I mentioned to you, the ovary secrete small amount. We already have our predetermined number of oocyte, and the ovary secretes small amount of estrogen, inhibiting the hypothalamic release of gonadotropin releasing hormone. Now, as we near puberty, okay, if leptin levels are adequate, hypothalamus becomes less estrogen sensitive. So the gonadotropin releasing hormone is released, stimulating the follicle stimulating hormone and the luteinizing hormone released by the pituitary. Then it will act on the ovaries. The events will continue until the adult cyclic pattern is achieved and menarche would occur, meaning the start of menarche is actually the start of the menstrual cycle. So right here, you could see it, okay, your gonadotropin releasing hormone is actually released in the hypothalamus. It stimulates the FSH and the LH secretion in the anterior pituitary. The FSH and LH now, the FSH and LH will now stimulate the follicles to grow. It is actually acting on the follicle to mature and secrete the sex hormones. The FSH stimulates the granulosa cells. Those are the granulosa cells surrounding the cells. Okay, the granulosa cells will release estrogen. And the LH, on the other hand, this LH here, will prod the theca cells to produce androgens, and which the granulosa cells would eventually convert also into estrogen. So there's increasing levels whenever there's this thing happen. There's now going to be increasing levels of estrogen, and the increasing levels of plasma estrogen will now exert a negative feedback. See that? Increasing levels will now result in a negative feedback that would inhibit the production of FSH and LH on the anterior pituitary. There's also the formation of inhibin by the granulosa cells whenever there is enough estrogen around. That will inhibit the production of FSH. And there's only going to be one dominant follicle that can withstand a dip in the follicle stimulating hormone. Other developing follicles will just deteriorate. So the positive feedback stimulates gonadotropin release. Estrogen levels continue to rise, okay, right here. And as a result of continued release by the dominant follicles, levels will reach a critical, very high value, and a brief positive feedback occurs on the brain and the anterior pituitary. This will trigger a surge in the luteinizing hormone. The surge, the really an abrupt surge in the luteinizing hormone triggers ovulation. That is the one triggering the ovulation, the luteinizing hormone. The high estrogen level also would trigger the release of stored luteinizing hormone and some follicle stimulating hormone by the anterior pituitary at the mid-cycle. The surge triggers ovulation, and the only one that really triggers ovulation is the luteinizing hormone. It triggers the primary oocyte to complete meiosis 1 to become a secondary oocyte also. The secondary oocyte then enters meiosis 2 and will continue on until it reaches metaphase 2. But that's it. It will stop at metaphase 2. It will travel along the fallopian tube as an egg, as a secondary oocyte, ovum, that is under metaphase 2 until it becomes fertilized. If it doesn't get to be fertilized, it will die as a secondary oocyte. So what does LH do after ovulation? Well, it increases the local vascular permeability. It triggers inflammatory response that promotes the release of metalloproteinase enzymes that weakens the ovarian wall. It stops blood flow to protruding follicle. It pretty much like also cause the wall to thin out, the bulbs rupture, forming a hole. So the oocyte with coronal radiata will now poof, break, and ovulation is there already. So I think I did this already. So if no fertilization occurs, the secondary oocyte will degenerate when the luteinizing levels start to fall. The sharp decrease in estrogen and progesterone, which in turn ends blockage of FSH and LH secretion, causes the cycle to start all over again. The oocyte is actually activated 12 months prior to ovulation, but matures 14 days before ovulation. So we're now into the menstrual cycle. The uterine menstrual cycle is a cyclic series of changes in the endometrium that occur in response to fluctuating ovarian hormone cycles. And it will have three phases: the menstrual phase, the proliferative phase, and your post-ovulatory secretory phase. So days 1 to 5 is the menstrual phase, is where you have your period. Day 6 to 14 is the pre-proliferative phase, the pre-ovulatory phase. And after ovulation, after 14 days, from 15 to 28 is the secretory, post-ovulatory phase. Now let's see what happens to the uterus. This is now a view of what's going on in your uterus. Now that we know what's going on in the ovary, with the egg, in the maturation, etc. Let's view the uterus. This is the uterine wall. This is the ovarian phases. This is actually what happens to the follicles, right? And these are the hormones. Right here are exactly the hormones that are produced by the ovary. And right here is actually the hormones, plasma hormone, that is actually produced by the anterior by the stimulation by the anterior pituitary gland. So from the first 5 days, which is the menstrual phase, and this is your menstrual phase right there. Okay, so that's the menstrual phase right there, menstrual phase. The ovarian hormones are very low. So your ovarian hormones are very low. Okay, your gonadotropin levels are beginning to rise. There you go, they're beginning to rise right here. Okay, the stratum functionalis, okay, right there, the stratum functionalis detaches from the uterine wall and it is shed off. And that's when you have your menstrual flow, that would last about 3 to 5 days. And after the 5th day, the growing ovarian follicles start to produce more estrogen. Okay, they are your growing follicle, and they start to produce. You can see the estrogen is actually rising. So from day 6, the proliferative or pre-ovulatory phase would start, and this is actually how your uterus would look like. It will start to grow, right? The rising estrogen level, you can see it, the rising estrogen level prompts the generation of new stratum functionalis layer. And this is how your uterus would look like. It will thicken. The stratum functionalis layer that was left off during menstrual cycle is now going to grow back because of the rising level of estrogen. And pretty much ovulation occurs at the end of this proliferative phase right there, where you could see that your uterus is already very, very thick. And what causes ovulation right here? You could see what causes ovulation. Let's go back right there with your plasma hormone level of your luteinizing hormone. It spikes right there. That spike in the luteinizing hormone will actually cause the release of the egg, ovulation. 15 to 28 is the phase that is most consistent in duration. The endometrium prepares for the embryo to implant. You could see that it is thickening. It is becoming more glandular. It is becoming more vascularized. Okay, it prepares for the embryo to implant. The rising progesterone level from the corpus luteum, you can see that there's actually a rising corpus level, okay? From the corpus luteum, this is your corpus luteum that was formed immediately after the egg has been released, okay? They actually produce the progesterone. And So the functional layer become a secretory mucosa. The endometrial glands enlarge and secrete nutrients into the uterine cavity. They think they're made up. They're actually like going to be thick with mucus. Okay, they form cervical mucus plugs that block entry of more sperm, pathogen, or debris. If fertilization does not occur, the corpus luteum would degenerate and will become the corpus albicans. Okay, you now have your degenerating luteum here. It causes the arteries to kink. There you go. Those are arteries. It will kink. It will become spastic. The endometrial cells will die. The glands will regress. The spiral arteries will constrict, then relax and open, and then causing a rush of blood into the weakened capillary bed. And the weakened capillary bed will break up. That's going to be the menstrual cycle. The first day of menstrual cycle will start. So let's take a look at some imbalances in the menstrual cycle. Amenorrhea means cessation of the menstrual cycle. Female athletes that have very little body fat. Okay, pretty much adipose cells are needed to convert adrenal androgens to estrogen and produce leptin, and it plays a very important role in puberty. The lack of leptin can shut down the reproductive cycle. Okay, so the adipose, our fat cells are the ones that produce leptin, and they are the ones that are needed to convert adrenal androgens into estrogen, which can pretty much like um, be a reason why some female, very um, um, female athletes that would lack fat would not have the menstrual cycle. It can reverse though if the woman will increase its body fat. A young healthy woman, you can still see dramatic bone loss like osteoporosis. Okay, usually seen in old age. Estrogens promote oogenesis and follicle growth in the ovary. They also exert anabolic effect on female reproductive tract. It supports rapid, short-lived growth spurts at puberty. They induce the development of secondary sexual characters like growth of the breast or increased deposit of subcutaneous fat and widening and lengthening of the pelvis. It has also metabolic effects. Estrogen maintains low total blood cholesterol and high HDL levels. They facilitate calcium uptake. So they modulate also osteoclastic activity, and they facilitate calcium uptake, and with lots of calcium around, the osteoblastic activity is promoted. So you're actually building up bones with estrogen. So when you lose estrogen, all of this will stop. Meanwhile, progesterone works with estrogen to establish the regular uterine cycle. It promotes changes in the cervical mucus. Pretty much there's also what we call placental progesterone during pregnancy that would inhibit uterine motility, and it will help prepare the breast for lactation. So here again, I've included this table from your textbook, which you can study for your final exam. So the female sexual response is just like the male, is initiated by touch and psychological stimuli, and usually orgasm is accompanied by muscle tension, increase in pulse rate, just like anything, rhythmic contraction of the uterus. Okay, and but orgasm and all of this is only like a sexual experience, but we do not have any refractory period after orgasm, and therefore we could still have multiple experiences in just one single sexual experiences. Multiple orgasm, I meant. So, but it is not really essential for contraception. The female libido is prompted by the dihydro epiandrosterone, an androgenic hormone that is produced by the adrenal cortex. So it goes on even after menopause, because our adrenal cortex continue to produce the DHEA even after menopause. I would like everybody to read on sexually transmitted infections and homeostatic imbalances. Make sure that you do that because they will be included in your final test.